Now, this is mood disorders. Primary abnormality is disorder of mood or emotions, also referred to as affective disorders. Depression, also referred to as unipolar depression or major depressive disorder. Epidemiology, second most prevalent psychiatric disorder according to WHO survey. Prevalence rate is varies from 5 to 17%, average is 12%. Very high prevalence rates. Every fifth person will have depressive attack once in their lifetime. Female is to male ratio is 2 is to 1. Onset usually in middle years of age. So onset is usually in middle years of age, 40 years. Middle years में होता है depression. Prevalence is increasing in young people too. Most common in single, separated or divorced persons. DALI, that is disability adjusted life years among psychiatric disorders, is maximum lost to depression. Overall, it is the second leading cause. First is ischemic heart disease. Most common cause of suicide. Most prevalent psychiatric disorder is specific phobias. Most common psychiatric disorder in India, excluding tobacco use disorders, is depression. Symptoms are SIGE-CAPS, okay. Sadness of the mood, depressed mood, persistent and pervasive. Loss of interest or pleasure, anhedonia. Guilt or feeling of worthlessness. Energy loss or fatigue. Concentration loss, cognition loss, negative thoughts. Appetite loss or appetite gain with significant weight changes, more than 5% change in 1 month. Psychomotor agitation or retardation. Suicidal thoughts. Suicidal thoughts are further classified into three. Grade 1, that is death wishes. Patient feels death should come to me. Grade 2 is suicidal wish. Patient says, I wish I could commit suicide. Grade 3 is suicidal intent. Patient says, I would be killing myself. So, death wish, suicidal intent. We should ask about it, about the suicidal thoughts. Early morning insomnia, getting up 2 hours earlier than the usual waking time. Hypersomnia is also seen in some cases. Reduced latency of REM sleep. Sleep is usually decreased, but it might be increased also. तो latency कम होती है REM sleep की. सीगे कैप्स, ठीक. Criteria for defining depression. From the above 9 symptoms, 5 must be present. At least one must be present out of the first 2 for at least 2 weeks duration. Specifiers: depression with psychotic features, that is delusion or hallucinations. Mood congruent or incongruent. Congruency means whether thoughts of the patient are matching with contents of delusion or hallucinations. For example, a poor person thinking that the world will end soon. Incongruent delusion or hallucination means when thoughts are not matching with contents of delusion. For example, a depressed patient thinking that he is powerful man alive. Okay. Psychotic depression, ICD-11 changes. Earlier it was considered as psychotic depression was part of only severe depression. Now it is said that psychotic depression can be seen in moderate depression also. Atypical depression, reversal of biological features, increased appetite, increased weight, increased sleep. Mood reactivity is present, mood improves with positive events. Leaden paralysis, subjective feeling of heaviness of limbs and difficulty in moving them. Leaden paralysis, subjective feeling होती है, एक्चुअली नहीं होता paralysis, but there is a subjective feeling of heaviness. Extreme sensitivity to interpersonal rejection, atypical paralysis. Treatment: response to SSRI and MAO inhibitors are better than TCA in these patients. So response to SSRI and MAO inhibitors are better than TCA in these patients. Depression with melancholic features, involutional melancholia. Significant biological symptoms, significant anorexia, weight loss, early morning awakening, lack of mood reactivity and anhedonia. Depression is worse in the morning, distinct quality of mood, feeling of misery, excessive guilt and marked agitation and retardation, increased suicidal risk. Melancholic features, involutional melancholia. Depression with catatonic features. Catatonic features discussed in schizophrenia can also be seen here. In ICD-11, catatonia has been made as separate diagnosis, discussed with mental disorder or substance use disorder. Endogenous depression, no clean-cut stressor is there. Endogenous depression. Exogenous depression or reactive depression is clear-cut stress is present. Physical signs are Varagoth fold, omega sign. Varagoth fold is a triangular fold on the nasal side of the upper eyelid. Not seen nowadays, Varagoth fold. Omega sign, omega shaped fold on forehead above root of the nose. Etiology, multifactorial causes, neurotransmitter disturbances like serotonin most common deficiency, norepinephrine dopamine deficiency. Hormonal disturbances like HPA axis overactivity 50% cases में. Cortisol hypersecretion, urinary, saliva और plasma cortisol levels tested, cortisol is hypersecreting due to HPA axis overactivity. Dexamethasone suppression test करते हैं तो high potency glucocorticoid not able to suppress the ACTH, CRH and cortisol surge next day. More definitive test है ये. Hypohyperthyroidism both present with depressive symptoms. Neuroanatomical considerations, decreased activity in the dorsolateral prefrontal cortex, increased activity in amygdala. Genetic factors, polymorphism in serotonin transporter gene. Promoter region has two variants, S and L allele. तो serotonin transporter gene में polymorphism. Promoter region has two variants, S and L allele. Patient having SS allele severe depression, SL allele intermediate depression, LL allele less severe depression. Psychological theory, cognitive theory given by Aaron Beck. He said that patients with depression have a lot of negative thoughts which are responsible for maintaining the depression further. Beck's cognitive triad, negative view of the self, ideas of worthlessness, negative view of the environment and others, ideas of helplessness, negative view of the future, ideas of hopelessness. Out of the three, third one is the most important because it is associated with more cases of suicide. Theory of learned helplessness. Due to repetitive adverse events, patient believes that he has no control over the events, loses the motivation to act. Beck's cognitive triad of depression includes negative view of the past, negative view of the self, negative view of the future and world and environment. ठीक है, तो सेल्फ के बारे में, एनवायरनमेंट के बारे में, फ्यूचर के बारे में. Drugs that cause depression as side effect are antihypertensives like reserpine, methyl-dopa, beta blockers. Steroids like OCPs and corticosteroids. Progesterone more than estrogen. Interferons, barbiturates, benzodiazepines. Treatment of depression, pharmacotherapy, onset of action takes 3 to 4 weeks. Drugs are chosen on basis of side effect profile. Duration of treatment at least 6 months or duration of the last episode. Prophylactic treatment indicated if 3 or more episodes are there. Chronic depression, depressive symptoms continuing for more than 2 years reduces number and severity. TCS, tricyclic antidepressants, mechanism of action is block serotonin norepinephrine transporters. Side effect is muscarinic, anticholinergic side effects. Adrenergic alpha 1, alpha 2 block leads to hypotension. Histamine H1 block leads to sedation. Cardiac sodium channels block cause arrhythmias. Example: imipramine, desipramine, trimipramine, amitriptyline, nortriptyline, protriptyline. Amoxapine, doxapine, maprotilin, clomipramine. Clomipramine is most serotonin selective. Desipramine is most norepinephrine selective. Clomipramine, desipramine. Most serotonin selective, most norepinephrine selective. TCA side effects and toxicity. CVS, postural hypotension, hypertension can rarely be present. ठीक है, CVS में postural hypertension is the side effect of TCA. Hypertension can rarely be present. Tachycardia, chest pain. CNS में altered sensorium, respiratory depression, convulsions. ANS में anticholinergic side effects like constipation, dry mouth, blurred vision, urinary retention, decreased sweating and delirium. Therefore, Glaucoma and BPH patients should not be prescribed these drugs. Then, what is this? Alpha receptor blockade, postural hypotension, rarely hypertension may be present. Metabolic acidosis, tissue hypoxia. H1 blockade, sedation, weight gain, hyperprolactinemia, amenorrhea, gynecomastia, galactorrhea, impotence, mostly with amoxapine due to D2 blockade. Important information: amoxapine causes D2 antagonism, leading to extrapyramidal side effects and hyperprolactinemia. ECG changes seen in TCH toxicity, prolonged PR, QRS and QT interval, AV block, right axis deviation, QRS more than 100 milliseconds. Treatment is alkalinization using IV sodium bicarbonate, mainstay of the treatment. Gastric lavage only helpful in cases of immediate administration. So alkalinization is the mainstay. SSRI, selective serotonin reuptake inhibitors, most commonly used. Mechanism of action is block serotonin reuptake, first line for depression and also for most of the anxiety disorders. Example: fluoxetine, fluvoxamine, citalopram, escitalopram, sertraline, paroxetine and vilazodone. Side effect is GI, nausea, most common diarrhea, constipation, most with paroxetine, anorexia. Sexual dysfunction, most common long-term side effect. Decreased libido, sexual dysfunction. Poor erection, delayed ejaculation, QTC prolongation. CNS, vivid dreams, sweating, anxiety, insomnia, sedation, seizures. Emotional blunting, extrapyramidal side effects, anticholinergic side effects like constipation, hematological inhibition of platelet aggregation, only of theoretical value, weight gain and hyponatremia. Drug of choice for premature ejaculation is SSRIs, dapagliflozin. Vortioxetine inhibits serotonin uptake. Agonism at 5-HT1A, partial agonist at 5-HT1B, antagonist at 5-HT3, 5-HT1D and 5-HT7 receptors. Vortioxetine. Serotonin syndrome, excess plasma concentration of serotonin, manifested when SSRI are given with MAO inhibitors, tryptophan, lithium. Life-threatening diarrhea, hyperreflexia, myoclonus, rigidity, increased temperature, seizure, delirium, coma, death. Treatment is cyproheptadine supportive care. Serotonin syndrome is more seen when SSRI is given with MAO antagonist inhibitors, MAO A inhibitors, then MAO B inhibitors. Which of the following is an adverse effect of a psychoactive drug that acts as a selective serotonin reuptake inhibitor? Sexual dysfunction. Now, which of the following is not an adverse effect of escitalopram? Sialorrhea. Serotonin norepinephrine reuptake inhibitors SNRIs blocks both serotonin and norepinephrine reuptake. Better results in severe depression. Examples: venlafaxine, duloxetine, milnacipran, levomilnacipran. Side effects are hypertension and anticholinergic side effects. Discontinuation syndrome occurs on sudden stoppage of the antidepressants, most commonly associated with venlafaxine, paroxetine, fluvoxamine. Discontinuation syndrome. Clinical features are finish, flu-like symptoms, fatigue, aches, etc., insomnia, nausea, imbalance, vertigo, sensory disturbances, paresthesia, hyperarousal, anxiety, irritability, hyperarousal. Monoamine oxidase inhibitors. Two types: MAO A and MAO B inhibitors. Non-selective MAO inhibitors: phenelzine, trenylcypromine, isocarboxazid. So phenelzine, trenylcypromine, isocarboxazid. ठीक है. Side effect is cheese reaction. Seen when patients on MAO inhibitors consume food items with high amounts of tyramine like cheese. hypertensive crisis happens, treatment is give phentolamine in crisis. Atypical antidepressants, SARI, 5H2, 5-HT2A and 5-HT2C, serotonin antagonism and reuptake inhibitors. Examples: trazodone, side effects is priapism; nefazodone, mirtazapine, NSSA, noradrenergic and specific serotonergic antidepressant. Central alpha 2 antagonism increase norepinephrine and serotonin firing. Antagonism of 5-HT2 and 5-HT3 receptors. Sedation, weight gain, vivid dreams, minimal sexual side effects. Bupropion, NDRI, norepinephrine, dopamine reuptake inhibitors, minimal risk of weight gain and sexual side effects or sedation. Side effects are insomnia, restlessness, seizures, and smoking cessation. Tineptive and amineptive. Tineptive, amineptive. Serotonin reuptake enhancers. Antipsychotics used in depression with antipsychotic features. Ketamine, IV infusion at sub-anesthetic doses, rapid relief in depressive symptoms and treatment of refractory patients. Rapid relief in suicidal ideation. Durability is questionable. In 2019, FDA approved nasal spray of S-ketamine. TRD treatment resistant depression patients given with oral antidepressants, self-administered at doctor's office. Suicidality and antidepressant drugs. FDA has issued black box warning for increased suicidal thinking and behavior in children and adolescents and later young adults. Recent studies have found that suicidal thoughts and behavior are decreased over time for adult and geriatric population. No difference found in the youth. Concept of paradoxical suicide. It states that in patient taking antidepressants, initially there is increased risk of suicide, so monitoring for few days and weekly monitoring is done. Psychotherapy. Cognitive behavioral therapy. Thoughts based on thinking pattern. It works by removing negative automatic thoughts, cognitive distortions, faulty way of thinking which stays with the patient. Interpersonal therapy. Behavioral therapy. Family therapy, psychoanalytically oriented therapy. So there can be psychotherapy, cognitive behavioral therapy, which are for the thoughts based on thinking pattern. It works by removing the negative automatic thoughts, cognitive distortions, faulty way of thinking which stays with the patient. Interpersonal therapy, behavioral therapy, family therapy, and psychoanalytically oriented therapy can be done. Other somatic treatments are electroconvulsive therapy. Indications are depression with suicide risk, depression with stupor, psychotic depression, and treatment refractoriness. Repetitive transcranial magnetic stimulation, non-convulsive, no anesthesia required. Vagal nerve stimulation, deep brain stimulation. Sleep deprivation, effective for short span only, no role in long term. Phototherapy used in depression with seasonal pattern. Important information: usual treatment of depression is SSRI plus CBT. Recurrent depressive disorder, more than one episode of depression. Dysthymia, symptoms of depression are present but are not severe enough to cause socio-occupational disturbance. Duration of more than 2 years, that is dysthymia. Chronic depression, full-fledged depressive symptoms for more than 2 years. Persistent depressive disorder, double depression, depressive episode superimposed on dysthymia. So, persistent depressive disorder, double depression, depressive episode superimposed on dysthymia. Bipolar disorder, lifetime prevalence is 1%, male 6 to female 1.1:1. ICD-11 classifies bipolar disorder into two types: bipolar 1 and 2. Bipolar 1 is mania plus depression, bipolar 2 is hypomania plus depression. Mean age of onset for bipolar 1 is 18 years, bipolar 2 is mid-20s. Symptoms of the mania are myasthenia, fast GDP. Myasthenia, fast GDP. M for mood elevation. A for activity levels are increased. F for flight of ideas. Abnormal increases levels of activity or energy. Sleep decreased. Need for sleep is also decreased. T for talkativeness, over talkativeness. Sleep is decreased. Need for sleep is also decreased. Talkativeness, over talkativeness. Grandiose ideas and increased self-esteem. distractibility, painful consequences, involvement in such activities. Diagnostic criteria 5 out of the 9 and both 1 and 2 symptoms required. Duration criteria at least 7 days. Then it is bipolar disorder. Psychotic symptoms mood congruent or incongruent, hypomania, symptoms similar but not severe enough, don't cause marked impairment. Duration criteria is 4 days at least. Duration criteria 4 days at least. Mixed episode both mania and depression for 7 days. Rapid cycling 4 episodes in 1 year. Important information: 2 episodes of mania are called distinct if there is a duration of 2 months in between. Bipolar etiology: neurotransmitters, increased levels of serotonin and dopamine. Genetic causes are 18q, 22q, 21q. Treatment of bipolar disorders depends upon phase patient has come now. Acute mania or mixed episode, mood stabilizer, lithium, valproate, carbamazepine, oxcarbazepine, lamotrigine, atypical antipsychotics, benzodiazepines. Severe mania or mixed, then use combination. Less severe mania, only mood stabilizers or only antipsychotics. Mixed episode, valproate is much more used than lithium. Mania with psychotic symptoms, antipsychotics. Drug of choice: acute mania, antipsychotic. Severe mania, antipsychotic. Pregnancy, prefer antipsychotic. Valproate is most teratogenic, can cause neurodegenerative defect. Lithium can cause abstinence anomaly. Acute depression, also called as bipolar depression. So acute depression, also called as bipolar depression, mood stabilizer, lithium, lamotrigine, have better effect in manic symptoms compared to depressive symptoms, except lamotrigine. Lithium has anti-suicide property. Olanzapine plus fluoxetine, quetiapine, mood stabilizer plus antidepressants. Lurasidone. Antidepressant monotherapy is avoided as it can cause manic switch. एंटीडिप्रेसेंट मोनोथेरेपी नहीं देते क्योंकि मैनिक स्विच हो सकता है. ECT मेंटेनेंस के लिए लिथियम वाल्पोरेट गिवन ऑन मेंटेनेंस थेरेपी. देन indications: 2 or more episodes or a single mania episode with significant risk. Continue for at least 2 years. Role of psychoeducation is also beneficial. Treatment of mania includes ECT, mood stabilizer, antipsychotic drugs. Lithium, first used by John Cade, monovalent cation, rapid and complete absorption after oral intake. Half-life initially 1.3 days, later 2.4 days. Okay, don't get metabolized. Excretion by kidney, don't bind to plasma protein. Indications: acute manic episode, bipolar depression, maintenance treatment if it reduces severity, frequency and duration of both manic and depressive episodes. Anti-suicide properties: schizoaffective disorder, major depressive disorder, neutropenia, OCD. Headache, cluster headache, migraine, ulcerative colitis, इन सब में देते हैं. माइग्रेन में, क्लस्टर हेडेक में, अल्सरेटिव कोलाइटिस में, OCD में, न्यूट्रोपीनिया में. Correlates of lithium responsiveness: euphoric mania. For dysphoric mania, valproate is a better drug. Euphoric mania में lithium. MDI, mania depression interval sequence less than 3 episodes, no rapid cycling. For rapid cycler, drug of choice is valproate. Family history of bipolar disorder, absence of comorbidities like substance use. Important information: tedium therapeutic drug monitoring it is required for lithium as it has narrow therapeutic index. Acute mania 1.0 to 1.5 milliequivalent per deciliter. Maintenance treatment 0.6 to 1.2 milliequivalent per deciliter. Toxicity happens when more than 1.5 milliequivalent per deciliter is there. Side effects: neurological, postural tremors, drug of choice beta blockers, lack of spontaneity, increased intracranial tension which is rare, and peripheral neuropathy. Endocrine: hypothyroidism, rarely hyperthyroidism, hyperparathyroidism. Renal side effects are most common is polyuria, may progress to diabetes insipidus. So endocrine में hypothyroidism करवा सकती है, rarely hyperthyroidism, hyperparathyroidism. Renal में most common is polyuria, may progress to diabetes insipidus. treated with thiazide diuretics, potassium sparing diuretics like amiloride, trimethoprim और spironolactone. नेफ्रोटिक सिंड्रोम करा सकती है, आर्टी रीनल ट्यूबुलर एसिडोसिस करा सकती है, इंटरस्टिशियल फाइब्रोसिस करा सकते हैं. डर्मेटोलॉजिकल एक्ने करा सकती है, रैशेज, वर्सन द सोरियासिस, हेयर लॉस, nausea, vomiting, weight gain, teratogenic side effects like Epstein anomaly, ASD, VSD. Lithium toxicity has narrow therapeutic index greater than 1.5 milliequivalent per deciliter. Precipitating factors are dehydration, low sodium diet, renal impairment. Clinical features are GI symptoms, abdominal pain, vomiting. CNS symptoms are coarse tremors and ataxia. Dysarthria, muscle fasciculations, increased DTR, convulsions, impaired consciousness, death. Management is stop lithium, correct dehydration, use of sodium polystyrene sulfonate or polyethylene glycol to remove unabsorbed lithium from GI. Hemodialysis in severe cases. Pregnancy and mood stabilizer. Pregnancy increases risk of relapse of bipolar disorder, leads to adverse impact on mother and child. Don't stop mood stabilizers abruptly. Lithium, if continued during pregnancy, is monitored by high resolution USG and echo by 6th and 18th week, as chances of lithium toxicity is high. Valproate, carbamazepine should be avoided in pregnancy as these are teratogenic. Lamotrigine safer than valproate and carbamazepine. Antipsychotics safer and preferred for manic episode. PMDD, premenstrual dysphoric disorder. New in DSM-5 ICD-11. Symptom onset is 1 week before menses, resolve within 1 week after menses stop. Symptoms are irritability, mood lability, depressive mood, anxiety, lethargy, edema, breast tenderness, weight gain, sleep and appetite changes. Socio-occupational dysfunction should be present. Treatment: symptomatic analgesics, diuretics, SSRI and benzodiazepine. PMDD, premenstrual dysphoric disorder, is listed as genitourinary disorder in ICD-11. Now, premenstrual syndrome, PMS, milder variant of PMDD, psychiatric aspects of pregnancy, postpartum blues, baby blues, experienced by 30 to 75% of female, transient symptoms like tearfulness, sadness, mood lability, sleep disturbances, onset is 3 to 5 days, lasts for days to weeks, support to mother is enough. Postpartum depression, DSM-5 depressive episode with peripartum onset, more severe 10 to 15% in 3 months of delivery. Clinical features are sadness, tearfulness, lability, sleep disturbances, anhedonia, suicidal thoughts, thought of harming the baby or guilt, history of mood disorder, family history of mood disorders, increased risk of future depressive episodes. Treatment is pharmacotherapy and psychotherapy. In 2019, FDA approved brexanolone for postpartum depression, continuous IV infusion for 60 hours. It is similar to endogenous allopregnanolone, which is a hormone that decreases after childbirth. ठीक है. Cognitive therapy. Postpartum psychosis within 2 to 3 weeks. Clinical features: initial tearfulness, insomnia, emotional ability, delusions and hallucinations. Baby is dead. She didn't give birth. Risk of harm to self or baby. Episode of bipolar disorder. Treatment is antipsychotics, lithium and antidepressants. And mostly recovery is complete. 2/3 patients have another episode in next 1 year. Suicide rate in India is 10 lakhs, 10 per lakh population. CSF levels of 5-HIAA, 5-hydroxy-indole acetic acid inversely relates with risk of suicide. अगर CSF में 5-HIAA ज़्यादा है तो सुसाइड का रिस्क कम होगा. हाइड्रोक्सी इंडोल एसिटिक एसिड higher the levels of 5-HIA, lesser the chances of suicide, decreases impulsivity. 5-HIA is a metabolite of serotonin. Most common method of suicide is hanging, followed by use of poisons. Causes are depression, most common cause of suicide, schizophrenia, alcohol dependence, borderline personality and antisocial personality disorder. Risk factor is previous suicide attempt, most important risk factor, previous suicide attempt. Signs of suicidal intent: writing a suicide note, male sex, hopelessness, age more than 45 years, substance abuse, divorced, separated, unemployed, chronic illness, family history of suicide, poor societal support, poor social support, sexual abuse. Parasuicide, act of self-harm with no intent to kill self. Copycat suicide, seen in adolescents. In this, person tries to attempt the suicide because his peer or the person he worships has attempted suicide earlier. Physician suicide. Suicide rate in doctors is much higher than the general population. Psychiatrists, ophthalmologists, and anesthetists is suicide. Paradoxical suicide. In depression, patient has thoughts of suicide. Paradoxical suicide क्या होता है? In depression, patient has thoughts of suicide, but he has no energy to act on those thoughts due to psychomotor retardation. Acts as a protective factor. When patient is treated with antidepressants, changes in thoughts happen later. Change in energy level occur early. In this window period, patient is more prone to suicide. Patient and family is instructed to keep away from roof, ropes, knife, and other potentially harmful things. A patient with severe depression was treated with TC. Okay. This is Varagut fold seen in depression. This is omega sign. Miscellaneous indicators of bipolar depression, history and diagnosis. Patient come with first depressive episode or symptom depressive episode. In future, same patient come with depressive episode 2 years later, recurrent depressive disorder. In future, same patient come with many episode 2 years later, bipolar disorder. Early age at onset, psychotic depression before 25 years of age. ये सब indicators हैं bipolar depression के. Psychotic depression before 25 years of age. Rapid onset and offset of episode, short duration. Recurrent episodes more than 5. Marked psychomotor retardation. Mood lability as a trait in patient. Family history. Manic switch and its management. Patient of depression on treatment with antidepressants develop mania symptoms. ठीक है, this is all about depression.